Hello everyone. Really is an honour to be here and invited here to talk on behalf of Northern Ireland, a business service organisation who I represent, and Health and Social Care of Northern Ireland. I'm minded as well of this quote in British Medical Journal last year by one of our consultant clinical geneticists who said that our electronic care record was the biggest, the most unheralded change in his lifetime. Moving DNA testing to second, which I'm sure we'll all agree it's right. So as Sean has said, I'm head of the eHealth programme, and I think I was just minded today, October 2009, we began this journey with a proof of concept. Actual execution began in October, the first go live was in December. And I think as Colin Henderson's fond of saying, I think it's doubled the cost of investment in Iran in that proof of concept every time we talk, Colin. It must be a small GDP of an African country now. But suffice to say, it began the journey and there was some good investment across the piece. I have a lot of slides to get through. I realise you may have seen some of these before, but I was caught between the old and the new audience. And I think the story is a good one. It's an award-winning story. It's won eHealth Insider Awards, Health Service Journal Awards. There's a Building Better Healthcare Award this year for our eTriage referral solution. So it has been a success, and I think it's useful to just rehearse some of the things we did to enable that success. So who are we? Northern Ireland Health and Social Care. I represent our Regional Delivery Services Organisation, which is the BSO. We have 5 health and social care trusts, 6 if you include our ambulance service, around 20 hospitals, 12 of which are major acute. Workforce about 54,000, 609,000 admissions a year, with an average length of stay of 6 days. About 4 billion or 50% of our total budget is spent in healthcare. 350 GPs, and we're about 80 by 100 miles. We are not big. We are a bit distributed, but about the size of Greater Glasgow and Clyde. Manchester, Devo Mank is about 1.5 times the size of our patch. At the end of the life of Northern Ireland, 1,000 people are transported by ambulance daily, 24 children are looked after in some form of care. We have 5,000 people in beds, about 85% population. 12,000 people are receiving nursing home or residential care, 24,000 receiving a care package, 28,000 seeing a doctor or a nurse, 84,000 people daily are being prescribed a medication, and thousands of local people are receiving help and support from our charity. There's lots of services to move around, lots of information to be shifted. If we want to reconfigure services and treat the patient with the right professional at the right point of care in the right environment for that patient, we need to make sure that we have information that can move around to support that care model. And it's 2015, it was actually 2005. The department strategy had 2 key intertwined strands: electronic care communications, GP modernisation, putting in networks, and the electronic care records. And I like to think we have succeeded with that strategy, with what we're going to tell you now. What we did next on that strategic journey, and sometimes we talk to colleagues, especially from England and throughout the world, our starting position, your starting position is very important to understand because it defines the foundation on which you can move forward. It defines how much you can do. We had a good infrastructure in place. We put in place networks, regional shared data centres, GP modernisation. We digitised our GP community. I think we've been largely 100% digitised for some significant time now. So we were well ahead of that game. Then we updated our GP systems, starting there, populated it with 1.72 million it was in 2004-05, and it was the first project I worked on, was getting health and care numbers onto the GP systems, which is a necessary foundation, strategic foundation for the operational needs to link records at some future point. Then we moved on to regional solutions, delivering regional solutions once for Northern Ireland, and our picture archiving communications solution still remains as one of the biggest in Northern Ireland that we've delivered. And that's the kind of thing you can do if you get your infrastructure right, if you get the foundation right, if you get your journey right at the start. So why we need an electronic care records? The story's rehearsed and will be rehearsed over the next 2 days 1,000 different ways. But most patients who you talk to think their information moves around the system. They think it's there. The sick patient doesn't refuse consent at point of care. We've had over 12 million contacts in our electronic care record, and no one has said no to that contact for direct patient care. Then they find out it doesn't move between organisations, it doesn't move between the functions. The same information is asked for over and over. Frustration, silos, we know the story. So we set out to try and solve that. But also, this story hadn't just a patient frustration and a patient perspective, it had a clinical and medical perspective. Because the doctor who really cared about his care had to go through a raft of systems in order to find out about a patient. 14 minutes of logging on the different healthcare systems in his hospital to try to find out what he wanted to know about the patient. That's just on one site. Patients move around Northern Ireland. How much do they move around? These figures here, we have 8 PAS systems in Northern Ireland. Nearly 700,000 are shared across 2 of those PAS systems. 4, which is the absolute minimum number, which signifies you will have moved across 2 trust boundaries in Northern Ireland healthcare. 250,000 shared patient records on different PAS systems. So patients were moving around. So the doctor who in his physical single hospital location had to spend 14 minutes logging into all those systems, referencing his manila folder case note, and then spending 1 minute with you as a patient, are asking you why you're here to see me, because 12% of the time, even the referral letter wasn't there to support his care, needed to be supported. So we've brought together in our electronic care record 8 PAS systems, 9 document management, 14 ED instances, 5 out of hours, 6 labs, 3 radiology, PACS, diabetes and cardiology. Diabetes, 5 paediatric diabetes systems, and then separately in each hospital 5 adult diabetes systems, which don't seamlessly progress the care of a diabetes patient from being a child to being an adult. 3 social care community systems principally, which we've now joined up, so we can now say that someone is on the Child Protection Register, is a looked after child, is receiving community service. We can bring all that information in, as well as our 350 GP systems, which give us our drugs and allergies through 220,000 messages every day to help inform better care. How do we make all this happen? There's loads of things you have to do, and one of the key things that we get asked about whenever we're visited by French, Spanish, Canadian, English, everyone wants to know, how did you get this data sharing up and running? We've some key principles. It's for direct patient service user care only. It's only accessed when there is a relationship, and we set up relationships. You could spend 30 minutes in this slide alone, but we set up those relationships through the role-based access models in order to give people, doctors, carers, the same access to records that they have today. Very complicated model. We ran an information campaign. We delivered 740,000 leaflets to homes throughout Northern Ireland, informing them, not asking could they opt in or out. Yes, we made the locking of a patient record for direct care quite difficult, but it was there, but it wasn't described as an opt-out. It was locking of your record, because the record, even the Data Protection Act, for direct patient care, it should inform the patient of what it is being shared. And we're now putting in place, so we're now challenged to do a data sharing agreement, and the data controller and common model is what we're using in order to harness all the goodwill and get some kind of service level agreement through the data sharing with all our trust colleagues in Northern Ireland. Has it been successful? Apart from the awards, which are the physical manifestation of success, we have this. I mean, it's been used in the care of nearly 57% of our Northern Ireland population, if the raw figure. Unique patient records means that if you all access my record once today, we only count that once. The next figure, 17 million, is if you all access my record today, we'll count it 72 times. We now have greater than 15,000 unique logins per month. 27,000 32,000 drug accesses per week. We took the emergency care summary from Scotland, the same model that we developed in Scotland, and we brought it over to Northern Ireland. And it was used in emergency and urgent care settings only. And at the peak of that project, and I was involved deeply in that one as well, there was 7,000 accesses per week to drugs and allergies. But once you put that in electronic care record and transform the model of care delivery and how it was delivered, 32,000, it's nearly 5 times the peak of another project, and we're still growing. The map's still going up, graph's still going up. But it's worth pointing out that 1.5 million people have still printed from our system. So you give them digital solutions and they'll still print because it's very hard and you know, culture eats strategy for breakfast and so on and so forth. But behaviour is the hardest thing to change. And behaviour is best changed from the inside out, and there's some good examples of that. 17,000 e-referrals are now viewed in electronic care record per week, and 10,500 out of hours reports. The out of hours reports are particularly interesting because they also now include the out of hours doctor writing back to the general practice saying, I used the ECR and made a different decision than I otherwise would have, quite often, and that's, we see that in our testing and we see that reflected back in feedback. This is the graph that just shows our cumulative view of labs is still going up. It's very, very impressive. The dips are obviously Christmas and summer where patients don't get sick, and we've stabilised a little bit. It's still gone up slightly, and I think it would still trend upwards. But if you look very closely at the last maybe 6 months, we're stabilising at about 200,000 views and accesses per week. And it's accessed by everybody. It's not accessed by the elite few or this person or that person. It's accessed by the whole gamut of our health and social care professionals. Consultants, that is 9% of consultants of our total active accounts, not 9% of the consultant base in Northern Ireland. So that's showing that everyone has an interest in patients' well-being and healthcare. But this set another foundation for us, another challenge for us, both technically and both organisationally, strategically. We wanted to do more for Northern Ireland. So doctors were saying, hey, if I had all this information 15 years ago and I built a couple of forms on top of it, I wouldn't have bought that system. And the other doctor wouldn't have bought the same system off a different supplier in another trust, and so on and so forth. And we started to hear this more and more. Can we do more in our electronic care record? Can we start using it for different things and exploit the opportunity? So we thought we were on a good foundation. We had a workforce, 95% of our GP workforce use electronic care record, using the one-bit button click context, patient context. They have accessed ECR 350,000 times in providing patient care since October 15. Out of hours providers, 351,000. And it's like schadenfreude when you look at these numbers sometimes, you know, because it's like a pleasure in the pain of others. But Boxing Day for out of hours, for anyone interested, has the most attendances and lookups on our electronic care record. 98% of our medical workforce. And we surpassed our business. Now, this was a big challenge for us. This is how unprecedentedly successful this was. We had business case 10,000 registered users for the 7-year lifespan of the project. And in 8 months, we had more than that in active users, not just registered. We also had a strategic vision underpinning the move to do once for Northern Ireland. We want our eHealth strategy published on March 16, empower people to be more active, and we heard this today. The theme is constant. It's a vein running through all of us, active in their own healthcare, deliver the best possible health and well-being for everyone, deliver better outcomes, measure better outcomes, rising demand, constrained resources, mention that, adopt best practices, reduce waste as ways to address that, support reform in terms of mobile working, integrated services design, so start integrating our service better. Modern ways usually involves, when you hear modern, it's usually technology underpinning what it is we need to do to support that. Use the digital solutions, avoid inappropriate care, reduce unwanted variations. Our Quality 2020 report and our junior doctor survey has said that in the top 10 things that frustrated them most was learning a new system to operate when they moved through trusts on their rotations. So let's give a single standard interface to how work gets done in hospitals. And all of this, I mean, we'll need investment in the technologies. Professor Rafa Bengoa from Spain, Luis Javier might know him. His writing a report which is due to be published in Northern Ireland very soon. We're all with bated anticipation of another report being published, but hopefully it will signify investment in the strategic technology needed to take us forward. So I want to fly through some of the things we've done on top of our base electronic care record, which was already award-winning. So we've done e-referrals triage, cardiology MDM, single ordering platform, common results acknowledgement platform in specific response to an SAI, care pathways for diabetes, and regional mortality and morbidity review system. E-referrals triage, God almighty, anyone in a hospital setting do referrals knows about this. So a while back, even before the CCG thing, the referral went in paper to the hospital. Then we created CCG, Clinical Communications Gateway, taken from our colleagues again in Scotland. Thank you very much. But what it did, Graham, was it allowed the GP to do an electronic transfer of information to the hospital. What happened when that electronic transfer of information reached the booking office? They went in and printed it out. We transferred the cost of printing to the hospital. We give them a cost. We give them no benefit. So they had to print it out, then it went through into the outbox of booking office, picked up by the porter, brought to the inbox to the consultant specialty, picked up by someone there, if you're lucky, within a couple of days, because really, really busy people, emergency situations happening all the time. Stamped, scribbled on, put back in the outbox, picked up by the porter, brought down to the booking office, and acted on at that point. 6 days, we're saying here. I think the doctors were just frightened to tell the truth, but that was the best truth they could tell. But 6 days, really good. So all that paper process, we digitized. There's no paper in our e-triage process anymore. It's referred through CCG. It's picked up by electronic care record. It's registered on PAS, outpatient registrations, 60%. No human interaction needed in the outpatient registration. We walk through the algorithm that the humans use today, and they've written out very concisely. The consultant sees a view, my referrals for today. He triages the referral. The outcome goes down, and because that outcome isn't always human readable or machine readable and needs a human intervention, the human reads that and then updates the PAS system. 15 minutes is our record from GP referring to an appointment being made. Transform care, with a really, really intransigent doctor who was leading in this. Why you picked the most intransigent person to lead on a new project, I don't know, but the trust did. And I was sitting with him and he said, it took me 15 minutes to do 10 referrals on that system, and it took me, on paper, 5 minutes, whatever it was, I forget. I said, that's great. I said, but have you accessed a laptop and can you work from home? He says, yeah. I said, well, you can triage at home. You can triage anytime you want. If something happens, you don't have to drive down a 60-mile journey between the hospital he worked in, between Causeway and Antrim in Northern Ireland, for anyone familiar with it. So he didn't have to drive down twice a week to pick up paper referrals that were there. We have a whole cohort of people physically located in a building doing registrations and booking only because the paper needs to be there. Better informed decisions. Some of our specialties, it's in 40 specialties now, some of our specialties are saying they have discharging 30% more patients because they have better informed information at the point of care to do discharge. We want that tested across all our specialties. I'm pretty sure it'll not trend that same way, but it's a very, very useful statistic. Cardiology MDM referrals. We had a situation in Northern Ireland where a few big hospitals do a lot of our cardiac work. And there was a sense, I don't know whether it ever became true or I don't know on it, but there was a sense that some of the patients who were in the big hospitals at the time were getting preferential treatment in terms of cardiology. So there was a lack of enthusiasm and engagement for the MDMs, which were done over voice video conference. So we put in place a very open and transparent system where you made the referral and the referral went on a list, and everyone in Northern Ireland who was a consultant cardiologist, consultant surgeon or vascular surgeon could see that information. The engagement right away more than doubled and trebled the engagement in the MDM for cardiology because it was open and transparent. People could see their decisions in front of them. They could move them forward. They all felt engaged. 3,758 patients referred, but you don't have to take my word for it. Now, I used to like to have a clinical colleague with me during this, but I don't today. Clinical Director of Cardiology in Belfast, one of the most senior people in his field in Northern Ireland, said this, the senior cardiac surgeon responsible for TAVI, and TAVI is a transcatheter aortic valve implantation or something, but it's about 25 grand a pop. And getting the right information to make the right decisions is really, really important before you spend that amount of money. Radiology ordering, single platform for radiology ordering. With 15% of all radiology requests are now done in Northern Ireland through the electronic care record. Big, big step forward, fantastic. With 1,400 users nearly. We're increasing every day. And when Belfast gets on, he's putting in a new system and we get this hooked up, we will transform. Belfast has never had anything or known of anything but paper referrals for radiology We call them referrals. It's investigation requests. People don't like orders because it implies you're being ordered. And it's going to go into our general practices who are also going to place a radiology request using the NICR. 1 click, 2 clicks, order placed. So we're transforming how everyone's doing business in Northern Ireland because we've got the right information in the right place, the right time. Care pathways, our diabetes pathway. I would love to have had a couple of our lead doctors with me today, but I don't, so I'll try to do it a little bit of justice. But we're trying to do a common patient pathway. When you ask anyone, what information do you need to support a patient on a pathway? And we all know this, Sally's laughing, but 65% is the same information, isn't it? Tell me their demographic information, their GP, their chemist, their pharmacist, what drugs, allergies they're on, what contacts they've had with hospital, what contacts they've had with their GP, where are they seeing anyone in a community setting, all that information. Tell me what you know about the patient, 65%. Then a little bit esoteric depending on the specialty context in which you're treating the patient. And we often put our finger over the word diabetes on this pathway because the hope is it just becomes common, because as you move forward, we reckon by about the 4th chronic disease on the pathway, it's a generic pathway at that point. What's the difference between a progress note for diabetes and a progress note? There really is none. But we need to keep it in scope and define it in order to crystallise the work we're doing so that it doesn't trend out. Look, reusability, anyone who did object-oriented programming and understands inheritance and super inheritance and all those things, and I'm sure we're all aware there's some good ideas fundamentally underpinning that, and it's reusability, common components and reusability. I mean, it's all about that. And it's very hard to make a new wheel, and there's very few things we're doing that are absolutely going to be game-changing. This has been, I think, a truly disruptive technology in healthcare, the electronic care record. So how do we graph this? Common building blocks. We have a set now of common building blocks, which, by the way, we want to expose through the core electronic care record. Why is patient contact details sitting in a pathway and not part of the patient demographic record? I don't know, but hopefully I'll find the answer, I'm sure, by the end of today, because it looks so fundamentally should be somewhere else, but we have to build it into a pathway. We want to lift the common components of the pathway and make them available to everyone. And when we do that, that's what can happen. Regional mortality morbidity review system, loose report, shipment, deaths happening, no one really understanding what was going on, lessons weren't being learned, so on and so forth. So our Department of Health, death certification and mortality policy department decided that they would implement a technical solution. Belfast Trust already had one up and running with dedicated doctors involved and people involved in that. And we bid against the business case. We bid as an option, an electronic care record, and we won that. Because you know what they do when they're reviewing deaths, those folks that did in Belfast? They had 2 screens. They had the morbidity mortality review system was just developed in Belfast, and guess what was on the other screen? The electronic care record. So it made sense that we brought those 2 things together. And what it's trying to do, the accuracy of a death certificate, quality peer review, assurance, learning, openness, transparency, and that's what the electronic care record, if you want words, it's openness and transparency. It does that for everyone. It really democratises patient care. All hospital deaths, go live imminent. We have 100 M&M teams established throughout the health and social care now. Every patient death will be offered for review, and forms created in the pathway include our initial record of death, the consultant review of death, M&M team review, and lessons learned. And all of that's recorded in a single place, on a single system, with the best informed information to support that. And that's what it looks like. That's what the medical death certificate that we're going to be digitally transferring to our coroner's office and our relevant GRO. And that's what the original, and that's what the original certificate looked like. So we've done a really good job, and we're auto-populating that. So this other one had no auto-population. You can see that's all handwritten pen. No one understood what was going in, what was happening. This is now auto-populated with as much information as possible. We have a future. We're going live today with problem list with around 12 specialties across our 5 trusts in Northern Ireland, which will allow doctors to input diagnosis, adverse reactions, alerts and allergies. And even though we have coded drug information and we have coded problem list information, we still can't do that contraindications, drug-drug interactions, drug problem interactions. We need to get there. We need to get there fast. We need to support this model. Medicines, we want to pre-populate our discharge ladder. Delighted that Sarah and Richard have said that we're going to see results coming into the discharge in the first quarter of 2017. I really look forward to that. Clinical intelligence. We need clinical intelligence. We need to be able to analyse an epidemiological population health that any patient presented through an electronic care record in terms of all the data for our relevant area in seconds. It should just be there. You should be able to tell if someone is X% at risk of something. I mean, a lot of what doctors do, a lot of what this does is algorithmic. It's they go through differential diagnosis down through a set of rules and procedures and give an outcome. We can mimic an awful lot of that. Patient portal. Want the patient to be involved in their healthcare. So look, what did we do? We used a single delivery organisation with big strength, our business service organisation. I would say that, but I do think it was a genuine success that it came from a central organisation. You can't do this by committee. You can organise the governance, but you can't do it by committee. We built on some of the technical platforms that I said we've done before. We nurtured our clinical champions, and that's really, really important. And we've used their greatest advocates. It organically grew because people were looking over shoulders and saying, how can you get access to all that information? How does that junior doctor know more about the patient than me so quickly? In positive, Langer's lottery tickets, for anyone who doesn't know Ellen Langer, and she does a lot of work in mixed, your mileage may vary, but she's done a lot of behavioural science work in the 70s. And it's the importance of positive engagement. It's not, I think it's called, the test was called the illusion of control, but it basically said there's 40 people in a business and we will let everyone, 20 would write their own ticket, write their own number in a lottery ticket, and it would cost $1. And the other group would buy a fixed lottery ticket at $1. And when the lottery got cancelled and you want to buy back the lottery ticket from the 20 who paid $1 for a fixed number, they give $1 back and that was happy. The group who chose their own number in this behavioural study wanted between $5 and $8 for their ticket because they felt that because they had an input into it, that they could decide the outcome positively. And it's about positive engagement. When we're involved in the decision, we're more positively committed to the outcome. That leads on to this because you need strong governance and SRO, strong information groups, strong clinical groups. Be clinically led. I think I've revised that over the last 6 months. I think you need to embed clinical leadership in your governance structures with your own IT leadership, with your service leadership. It needs to be a combined leadership. IT is a great cover, a great foil for a lot of IT projects because when it goes wrong, it's IT, and when it succeeds, it was clinically led. That's life. We accept that. That's our role in the business, right? You understand that. But that clinically embedded, all our groups, all those groups we talked about, every one of those other projects is chaired by a doctor or a relevant health and social care professional. It also has IT leadership, it has program and project leadership, it has service leads, it has the experts. We're putting round pegs and round holes, and it's helped us succeed. Know your organisation, strengths, capabilities. I mean, it's an old saying from the 80s and HP and Xerox and so on. I mean, it was like if HP knew what HP knows, and it's about knowledge sharing. People thought knowledge was power. Knowledge sharing is power. Mr. Bacon was wrong. The more we share our knowledge, the more powerful we become as an organisation. The more powerful our doctors become, the more powerful the outcomes for our patients. Our knowledge isn't power. Knowledge sitting in a silo is useless. So know yourself, know what you're good at, and put the right people in front of your projects. Put the patient, not the institution-centred decisions. I mean, I go on and on and on about this, but a hospital is not an attribute of a patient in anyone's mind, least of all the patients. Keep moving forward. You can wait in perfect if you want, but you'll never get there. So go forward with what you can safely move forward with. There's a reason you get, I don't know what it is, 200 Twitter and Facebook and YouTube updates a year because they're not perfect. They're changing all the time. But adapt to that change. Some benefits, folks. Like I need to tell you, it worked really well for us and is it continuing to grow? It is. Avoidance of laboratory tests. avoidance imaging, improved management, reduced need for a review appointment. A review appointment costs like £110, and there's 1 million of them a year. Extrapolation of some of that. That's a further 0.25% reduction, not 25% reduction. Just 0.25 was equaling £250,000 if you could reduce your review appointments through the use of technology. Virtualise clinics, do different things rather than make people traipse halfway around Northern Ireland for a half day of their time for 10 minutes of yours. Right? Change how we do business. And we can see these speak for themselves. This was 25% feedback to one of our surveys. This wasn't stuff we made up. We have it, it's on record from all across the health and social care professionals in Northern Ireland. It's quite astounding, some of the things we've got back. I'm just disappointed that only 79.6% thought it improved the quality of care. I would have thought it would have been more. But we'll work on that. And maybe that's because some of the folks were administrative and didn't maybe respond to that in a way. But I would have expected that to be higher. I think our goal for that was 80% on our benefits metrics and our business case, so we missed that one. So folks, I'm minded, finally, that we're in sort of Francis Crick here and DNA and nucleic acid and what sort of means. And I look at healthcare, and I think in order to sit in the forefront of healthcare and do the program project delivery and take the flag and sit in that intense zone, you need to have healthcare in your blood. It needs to be in your DNA. It's vocational. There's no one who gets involved in IT delivery of healthcare because they think the crack's good. Because it really, sometimes it is, but mostly on Saturday and Sunday. And not for the patient either, but that because it's tough. It's tough. We need our vendors working closely with us, understanding what our needs are, understanding where we're going, understanding where we want to be. And we need to know where they're going because, we can't go anywhere you're not as customers. We can say we want to go this place or that place, but we need to move forward together. And I think it's appropriate that we're in this institute today, which is a really, really fantastic environment for delivering. I think the experiences and knowledge we're sharing today on healthcare, folks. It has been a pleasure for me to be here, and thank you again, Loughran Health, for inviting me. I hope you all found that some of it new, some of it interesting, and if you didn't, well look, I'm sure it was interesting the first time you heard it. So, thanks very much for your time.
Hi Gary, Colin Henderson, Loughran Health. Your radiology orders graph took off after 6 months.
Yeah.
Why was that?
The implementation expanded throughout the other trusts, so each trust had to work up its own project team. We guide from the centre. There's no point us getting in and delivering because it doesn't work. It needs to work from the inside out, Colin. You know this as much as I do. So our job is to guide, inform, educate, provide the local organisations who we're delivering to with all the knowledge they have to be self-sufficient and sustainable. And as we develop each of those project boards and implementation teams locally, then they're able to take off. We haven't got all the trust to that level yet, but we're working on it, and it's very close, and we do expect to see nearly exponential growth. We hope to turn off all other radiology ordering systems early in the new year, and then we go to work in Belfast.
Gary, what do you reckon your total savings with?
Radiology orders, it's a challenge. It's a challenge to get quantitative feedback on that, Ian. And I'll always say, if we realised all the benefits of our business cases, we'd be handing the patient money on discharge. But unfortunately, that's not the reality of our business. It's a lot of qualitative analysis. We meet unmet need. We're more productive. We're more efficient in what we do. I don't think we can actually even, and I'll go back to something you said earlier, I don't think we even have the right information to properly measure ourselves today to understand our baseline. So we're ill prepared, I think was the phrase used. I think we're ill prepared to actually measure where we are from where we need to be. And we need to get a goal. We need to understand what our goal is.
So probably for sort of saving when you just have more throughput.
Absolutely, there's more productivity. I think there is evidence of more health and care numbers being seen in the system. Is probably the biggest benefit. But all those benefits are real. You can't, some of it, we always try to put a pound sign against it, and I understand that, but some of this is just strategically necessary to build the foundation to allow the real change to happen here. And it's then we'll be able to measure the true benefit.
So what do you think the remaining waste is?
I still think we have, I think we need to redesign how we move our patients around properly. And we are moving the Federation's GP stuff. Well, I don't know if we're actually moving, but we're doing things like Project Echo, which is allowing video conferencing of GPs and specialist experts to talk about things and try to empower more knowledge in the general practice community to allow them to make better decisions, so that I suppose the patient doesn't always end up having to do the half-day journey for 10 minutes of a doctor's time. We need, but we need the information there to move this around first, and I think we're just getting there. I think some of our slower learners, slower adopters are starting to realise the benefit of what we're doing, and it is a challenge. I'm sorry I can't put like massive pound signs. There's a big benefit in this, but if you start putting pound signs again, someone might ask you for it.
Thanks, Gary. I really enjoyed that presentation. And I'm delighted that Scotland gave you the emergency care summary. So in return, you'd like to nick your care pathways. So I suppose my question was more around the sort of analytics thing to pick up on Ian's point today about, I mean, you're collecting a lot of information, a lot of transactions, and moving to that patient-reported outcome measures and outcomes rather than activity measures, because a lot of your stuff was around activity focus. So I just wondered, in terms of your strategy and your plans around that sort of analytical capability, that actually records around outcomes and gives better feedback around the outcomes.
We do have in Northern Ireland, a regional data warehouse from our business service organisation, which can answer some of the really hard questions over time. But it was, and you're right, Sally, because I was struck by a conversation I had with one of our ophthalmology directors in our Health and Social Care Board the other day. And the question was, how many people with diabetes, this goes to the point, Ian, I suppose you're saying as well, how many people with diabetes have attended an ophthalmology outpatient clinic or are on a waiting list for an ophthalmology outpatient clinic? A, we barely know all the people with diabetes in Northern Ireland. B, joining that up with, because the primary and secondary care domains are managing diabetes, joining that up with the people who go to see an ophthalmology waiting list and or have actually attended is very, very difficult. We can't get there. But it's a slow, hard, arduous journey. And all of that was to say, are there people we don't need to invite for screening? Dead simple. And that sounds really simple. Do you know how easy that was to say? And probably a fortnight of maybe more. It might not even be possible to get that answer.
And I just wondered, again, in terms
So we do need to move the analytics. We do need to be quicker, more agile for some of that. Some of our queries still need where we don't have, where it's direct care linked, where you can produce it for clinical audit. We need to be more agile and provide more real-time feedback. I would really love to get the sense, what I said, of analysing the whole population in terms of the patient who's in front of you and giving the doctor immediate feedback.
I think
that's something, but the whole piece, we are not where we need to be in that, but I would really want to be in the analytics
and we're exactly the same, but we're struggling with that, and certainly around the care pathways, around that stripping out the variation. But when you describe that, depending on who the stakeholder is, from a financial point of view, it will be around stripping out the variation and cost. But from a clinical point of view, it's about good outcomes and improving those outcomes, and it's difficult to provide the evidence around that at the moment. So I think we agree there's a big piece of work we need to do around that.
But even in terms of knowing who you are, I mean, even we're studying this, sorry folks, don't want to labour it, but even trying to find out what drugs a patient's on, because we have 10 diabetes systems that are given different diabetes drugs which aren't recorded by the GP. So we have 2 sets of data, and then we have hospital dispensed drugs, and we're trying to join all this together to get a single best view of what a patient's drug list is. I mean, who would want to be trying to reconcile that? And it's in that reconciliation process for a simple outcome. A good analytics system could give you a good reconciliation process like that. And that's where we need to be. But we need to get all the data we need to look at first. And I think there's a bit of knowing you, knowing me kind of, we need to go through to get there. Sally, I hope that answered your question. I'm not sure, but I think we're both trying to do the same thing.
And I suppose the issue was around Ian's point around the move. And again, as a vendor, is there any support we can get from Orion and the product set that allows us to help that analysis?
Just knowing what patients the drug's on is actually quite a complicated question, even though they've been prescribed, they've been picking them up. So you need some basic machine learning and saying, they haven't picked them up, so you can let them script there.
Yeah. And adherence is a completely other question altogether, right? So we can do all the things, and then you get the adherence, and who knows? But you can only use the best information you have at any given time, right?
Hi Gary, thanks for the presentation. As you know, Dorset is at the beginning of their journey, and you mentioned the importance of clinical-led engagement. But I just wondered, at the beginning of your journey, how important was sort of the customer-patient engagement? Did you engage quite widely with them?
We did. We have a patient-client council in Northern Ireland. We would have presented through those an awful lot. Got our GP community, who are in many people's eyes, the initial contact for the patient. So we did go through, I think, as robust a process as we could to engage with the patient and their representatives in order to get some feedback. And we did use actual patients in the early days of the project to illustrate the benefits. The patients would have come forward, and there was a particular patient who still lets us use her data today, but she would have said and explained how the quality of her care was so much better because the doctors were more informed, even able to ask her, I see you were in ED in another trust 2 weeks ago, is your ankle okay? So that quality of care we started changing the conversation a little bit. Another significant thing from our patient was we did do in the outpatient audit. We were given access to speak to the patients about what they thought of the record, what they thought people knew. And usually you got the look of stunned look when they said, oh, you don't know about this? No. And you would highlight they would highlight to you actually, the discrepancies, the problems it caused, tell you their journey, their frustrations, their pains about being asked who they are 10 times in a 2-day visit to a hospital. So the patients actually were a very important part of what we did. It's a difficult engagement because, you know, you're asking several people to represent the nation. And that's a challenge. And we went through our patient client council, which we had set up to do that, who are our patient voice in health and social care in Northern Ireland.
Thank you.
Is that okay? Yeah.
Gary, I was going to ask you a similar question. That is, as you embark on the patient portal, how active is that consumer patient user group?
Can I give you the mic so everybody else?
We actually met with our patient client council, and we field questions constantly from them on when am I going to be able to look at this in the house, when am I going to be more involved in our care. It's a policy from our Department of Health to try to put the information. I think our Deputy Permanent Secretary for Health at Christmas said, just before Christmas last year, which was given as an award of course, said that if she had one wish for Christmas, it would be that a patient portal for Northern Ireland was there. We are obviously Dr. Google's there, but you know, we don't want to give patients bad diagnoses that haven't been intercepted by professionals on a Friday evening, and they spend all Saturday and Sunday worrying about it. So we have to be careful. We don't know what that means because we haven't done it yet, so we don't know what we don't know, but we think it'll be a really good idea and something exciting we hope to deliver.